We're going to start off with cases, and we have some interesting cases. And so our panelists include Dr. Huff, who's an associate professor of oncology and medicine and the medical director and chief medical officer of the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. She's also a member of the NCCN myeloma panel. Dr. Landgren, chief of the myeloma service at Memorial, and professor of medicine at Weill Cornell, and Dr. Somlo, who is a professor in the Department of Medicine, of Medical Oncology and Therapeutics at the City of Hope, and a member of the myeloma panel. I welcome them all to join us up here on the stage. George, I think you're first, right? There we go. So take it away.
Thank you very much. Thank you for the invitation, and I hope you'll be entertained by going through these three cases, and we'll have a lively discussion. So I was assigned to present a case with MGUS. So this would be the educational objectives, and hopefully by the time we are done with our three cases, you will know the difference between how to manage MGUS, smoldering myeloma, and learn the intricacies of how to diagnose and deal with renal failure. So let's start out with an audience question. And the question is it true or false that MGUS will evolve into multiple myeloma in every single case? 8% of the audience will be convinced for now that MGUS will evolve into multiple myeloma. And then there's the second question, that there's never any chromosomal abnormality at the stage of MGUS before a patient evolves with the disease into either smoldering myeloma or full-fledged multiple myeloma. And again, the answer here came in, I guess, is 5% of the audience who thinks that there's never any chromosomal abnormality. So the majority of the audience is cognizant of the fact there could be chromosomal abnormalities even in the MGUS stage. So with that, one more question, and this is to address whether close monitoring of patients with MGUS who will be not in need of therapy may actually improve survival. So is it true or false? And the majority of you thinks that careful monitoring actually might improve survival, and we'll get to the answer in a few minutes. So here's a case study. This is a 65-year-old male who presents with sudden back pain after playing golf. And he is not one of those who visits his physician frequently, and the last physical evaluation occurred about 5 years prior. So he goes to his primary provider, who orders a variety of diagnostic tests, and those are scheduled in about 4 weeks. And by the time the tests are done, the patient is actually completely asymptomatic. But the chemistry panel does reveal some abnormal findings, and the SPEP and IFE ordered reveals some monoclonal IgG kappa spike. So the primary physician asks for a hematology consultant who performs a complete myeloma workup, which includes the usual suspects. Bone imaging, free light chain testing, and urine in the blood is carried out as well, and there is a bone marrow biopsy performed. The skeletal survey does not show any lesions. There is a free light chain ratio, which is abnormal, and there is a myeloma protein, which is 1.3 grams per deciliter. And on the bone marrow biopsy, there is 8% clonal plasma cell involvement, no sign of amyloidosis, and there is a fluorescent in situ hybridization detected clonal abnormality, translocation 4/14. So where do we stand with this patient? So this was an incidental finding. The patient really had no symptoms by the time he was evaluated, but nonetheless, an abnormal myeloma protein was found. So MGUS is a classification which is defined by having a myeloma protein of less than 3 grams per deciliter, which is the case in this patient. bone marrow clonal involvement less than 10%, and there are no myeloma-defining events. And those events are affectionately abbreviated by CRAB, so it's calcium elevation, renal insufficiency, anemia, and bone disease, which at least by the skeletal radiography performed here was negative. So this patient does not have any myeloma-defining abnormalities or symptoms. So a little bit about the epidemiology. Multiple MGUS is found in about 3 to 4% of the population over age 50. There is an increased incidence with family history, and it's higher in African Americans in terms of its incidence. And what's important that based on the IG or the other immunoglobulin subtypes, it may evolve into different diseases. So for example, IgG elevation is more likely to be associated with the patient eventually developing smoldering, as you're going to hear about this in the next presentation, or symptomatic myeloma. And IgM subtypes are more along the lines of turning into lymphomatous pathway, and particularly Waldenström macroglobulinemia. And light chain MGUS may evolve preferentially into light chain multiple myeloma. So here's your next question. MGUS will evolve into symptomatic multiple myeloma at 1.5% per year, regardless of the type and amount of M protein. Is it true or false? Okay, so this is a close call. If this were an election, we would be in trouble. Actually, we are already in trouble. So moving on. These are some of the risk factors established over the years for predicting for MGUS progression, and this is the reason why monitoring patients with MGUS carefully, at least at a 3 to 4 month interval, is important. So there are a couple of papers listed at the bottom of this slide, but to sum them up, if the M protein is relatively low at the time of presentation or diagnosis, less than 1.5 grams per deciliter, and if it's an IgG subtype, and there's a normal free light ratio, then this case would be considered low risk, and the absolute risk of progression by year 20 is about 5%. Going down to the bottom, if there are 3 risk factors, that patient would be categorized as high risk, and that would include someone who presents with an M protein of greater than 1.5, but obviously less than 3 grams, because that would push this patient over into a smoldering category. And if it's an IgA subtype or an elevated normal free light ratio, those 3 risk factors together would increase the likelihood of developing symptomatic myeloma to 65% at 20 years. Here are some additional, more refined risk factors: high levels of circulating plasma cells, elevated bone marrow plasma cell proliferative rate, transformation into smoldering multiple myeloma, and you'll hear a little bit about that in the next presentation. And this is not always accurately available, but if there is a plasma cell phenotype by flow cytometry of greater than 95%, and there is immunopoiesis, again, there's a 50% likelihood of 2-year progression. And then certain chromosomal translocations, as defined on fluorescent in situ hybridization, will also predict for not too good of an outcome. It's unclear what's the ratio of progression with decreased creatinine clearance, but obviously once you get to renal dysfunction, you're actually going to have a patient with CRAB criteria. So in terms of staging for multiple myeloma, once either MGUS or smoldering myeloma case moves on to the symptomatic disease, our staging system has really been simplified, but I'm just making the point that even in the staging of full-fledged multiple myeloma, we are already incorporating some of the chromosomal abnormalities seen by fluorescent in situ hybridization. So if the patient I just presented to you already has the 414 translocation and does evolve into full-fledged multiple myeloma, then the prognosis is likely to be worse. So these are the answers. MGUS will not evolve into multiple myeloma in every case. MGUS will evolve into multiple myeloma at 1.5% per year, regardless of type and amount. No, that's not correct, as I just mentioned to you. If you have a patient with IgA multiple myeloma, for example, then the likelihood of evolution is worse. There's never any chromosomal abnormality. Well, that's clearly not true. A majority of the patients might already have the clone, which eventually will evolve into multiple myeloma. And close monitoring of patients with NGUS may actually improve survival. And thank you for your attention, and I'll yield to the next speaker.
Okay, so we will move on to the next case. So I'm going to start off with a presentation of a case. This is actually a patient I care for. A 72-year-old gentleman who was referred by their primary care provider for evaluation of a monoclonal gammopathy. The patient is asymptomatic and his examination was normal. Notably, he has a family history of multiple myeloma in his mother in her 90s. And the laboratories that were obtained are summarized here. These were available at the time that he came for evaluation. You can see a normal white count of 6,340. Hemoglobin was 11.9 with hematocrit of 36.9. Normal platelet count. BUN and creatinine were normal at 14 and 1.1. Total protein was 6.1, albumin 4.1, and a normal calcium at 8.9. IgG, IgA, and IgM were all a little bit low at the numbers respectively. The serum protein electrophoresis was negative, but the serum immunofixation showed lambda light chains. And the kappa was 8.4 with a lambda 273 and a ratio of 0.03. The 24-hour urine showed 130 milligrams of protein, but no M spike. Beta-2 microglobulin was 1.86. LDH was normal at 140. The urine immunofixation did show lambda light chains. And a skeletal survey had been done, which showed no evidence of lytic lesions. And so the next question is, what, if any, additional testing would you like at this point in time? A bone marrow aspirate biopsy, a PET CT scan, a whole body MRI, FISH analysis, nothing more is needed, or all of the above? So I think it's an excellent question. The question was, why did the primary care provider look? I'm gathering, I actually couldn't go back to the notes to see. I think partly it was the patient's mother had been diagnosed with myeloma and the patient's hemoglobin was slightly lower than the normal range. And in doing due diligence, it was looked and assessed for. But I think it's a fair question because I was looking back through my notes to try to refresh my memory why this was even sent in the first place, and I can't recall. Okay, so the audience, the majority would actually do a bone marrow aspirate and biopsy at this point in time. 9% would do nothing more, and 23% would do all of the above. And I guess I would turn to my panelists and ask them, what would you do at this point in time for this patient?
Well, I think that the workup with the bone marrow for sure is very appropriate, and that's what most of the people said here. I think that would be my first step.
I tend to agree with the majority.
I would agree as well, and the only next step I would order at this point would be the bone marrow biopsy. And so, in fact, the patient did undergo a bone marrow aspirate and biopsy, and it showed 10% lambda-restricted plasma cells. And if you recall from Dr. Somlo's presentation, and I'll refresh your memory again, 10% to 60% plasma cells is enough to make a diagnosis of multiple myeloma. And so, at this point in time, the patient is now given a diagnosis of multiple myeloma. And so now the question is, what to do at this point in time? Would you 1, obtain a PET CT scan, 2, a whole body MRI, 3, watch and wait, or 4, begin treatment? Okay, so we have a nice split. So about a quarter would get a PET CT scan, 13% an MRI, a third would watch and wait, and 30% would start treatment. And so I guess I would again turn to my panelists and say, what is your preferred next step at this point in time?
Well, in terms of the imaging, the latest guidelines do encourage us to use more sophisticated imaging technologies, PET CT or whole body MRI, if the skeletal survey is not helpful and we are trying to confirm the diagnosis. But although this is kind of a tricky question, we already established that this patient does have myeloma. So one could argue with the caveat that yes, you can do additional imaging as you feel it necessary, that beginning treatment may not be unreasonable at this point.
I would agree with that. I think in my experience, for patients that have been worked up with a skeletal survey that's negative in this very setting, in my experience, around a third of them do have detectable bone lesions by PET-CT because it's about 30 times more sensitive. And I think the MRI, we know through wherever we image the body, is a better technology for soft tissue. So we're looking for hard tissue, the CT is better. So therefore, I would use the PET-CT. I would agree, we already have a diagnosis of myeloma, so does it really change anything? Well, I do think if you're going to treat, we probably want to know what it looks like in the patient. So I would do it just for completeness as a benchmark.
Very good. I would actually argue it does change things because although we have a diagnosis of myeloma, we haven't yet identified whether we consider this patient to actually have active myeloma versus smoldering myeloma. So what you can see on this slide here is another representation of the IMWG criteria here, the MGUS criteria that Dr. Somlo went through. In the middle category are the smoldering myeloma criteria. So they are patients who, in this case, he has 10% or more clonal plasma cells, which puts him into the smoldering category. But he doesn't meet criteria for the myeloma defining events. Even though his hemoglobin was 11.9, which may be slightly lower than normal, it doesn't meet the threshold criteria for anemia. And although he has no lytic lesions on skeletal imaging, we haven't yet ruled out that he doesn't have bone lesions with other modalities. Because if you see the far right-hand side of the slide, under active myeloma, these criteria have recently been updated to include in myeloma-defining events not just CRAB criteria, but change the limit for clonal plasma cells. If it's 60% or more, they now have active myeloma. If that free light chain ratio is greater than or equal to 100, and that being involved divided by uninvolved, so either kappa to lambda or lambda to kappa, depending on which the patient has, or greater than 1 MRI focal lesion, any of those things would be significant enough to make the patient have a diagnosis of active myeloma. I would say at our institution at the time that this all occurred, which was prior to these changes, I still was performing PET-CT scans to look for bone disease because it would in fact change how the patient was approached at that point in time. So the patient went on to get a PET-CT scan that had no evidence of bone lesions, and a diagnosis of smoldering myeloma was made. And so now the next question is what do we do with that information? So on the basis of the available information, would you, 1, start therapy, 2, repeat the labs in a year, or 3, repeat the blood work or the laboratory assessment in 3 months? And so 80% would repeat the lab work in 3 months, 15% would start therapy, and we'll go through who we might consider treating at this point in time in follow-up. But I think as Dr. Somlo alluded to you, that we would tend to follow these people closely. So an optimal follow-up at this point in time, if you were going to do lab work, would be follow within 3 months. So like the MGUS patients where we can risk stratify them in their risk of progression, we also can do the same with smoldering patients. And there have actually been 3 different groups that have reported on this, the Mayo Clinic and the 2 different reports from the Spanish group. And what you can see, the risk factors differ a little bit, but they're based on, in the Mayo experience, the percentage of plasma cells, the size of the M protein. Again, now this patient, our patient doesn't have an M protein, and a free light chain ratio that is either low or high. So based on this, the patient in question has 2 of these criteria and would fall into this intermediate category with a projected risk of progression of 50% at 5 years. The Spanish criteria look at suppression of normal immunoglobulins, which he has, as well as looking at flow cytometric analysis of the plasma cells, which is not a readily available technique, and I cannot tell you what he had. So he would have at least 1 criteria based on that, again, putting him in this category with about a 40%, 46% risk of progression at 5 years. There is, and this just pictorially shows you risks of progression. So Without risk stratification, MGUS patients on average have about a 1% per year risk of progression, but that's certainly not all of them. And smoldering myeloma patients have a much greater risk of progression, particularly in the first 5 years. So on average, about 50% of all smoldering will progress. Being higher risk is greater than that, as you saw on the previous slide, about 75%, lower risk about 25%, averaging out. But that risk seems to level off if patients make it out 5 years, and the later risk of progression lessens over time. So not all of these patients will need to be treated, but a significant percentage will progress in 5 years. I don't have it in here in the interest of time, but the data that we have available on treating patients really is treating patients with high risk smoldering myeloma, and the majority of other patients we are putting in clinical trials. So given, or I should say even high-risk patients go into clinical trials. So given the fact that this patient does not have high-risk disease, he was followed expectantly with laboratories every 3 months looking for changes suggestive of a myeloma-defining event based on the CRAB criteria, and also following the markers that this patient has, namely the light chains in the serum and in the urine. So 4 years later, this is the patient's laboratories. His CBC is largely stable. Kidney function is normal. Calcium is normal. 24-hour urine now has a spike of about 270 milligrams of protein. And the lambda has now risen from about 250 to 450, and the ratio is now 0.04, or if you flip it around, it's about 200. Gets a repeat PET-CT scan in light of the changes that are present to look for any bone disease, and no lesions are identified. And so the question here is, what would you do at this point in time? Begin systemic therapy, continue to watch and wait, or do additional testing? And so 46% would start therapy, a third would continue to watch and wait, and 23% would do additional testing. And so I would ask my colleagues, what would you do at this point in time?
So first of all, I would like to clarify and correct myself in my answer to your previous question. When you asked me before if I would do PET-CT or not, I said the patient already had a diagnosis. I missed the detail. I saw the patient had smoldering, so that would be the reason to rule out myeloma. So I just want to clarify that. To answer this question, the right answer here, I believe, is to start therapy. But I think that because it's only based on the light chains for right now, in my clinical practice, I probably would repeat the light chains one more time, because they can be very jumpy around type of thing, and they can be sometimes back to low numbers. I probably would do that, but if confirmed, then I would start therapy.
I agree, and again, I missed the same point. So the imaging in that particular case would have been important.
I really wanted to just illustrate the subtlety to make sure that people were not relying solely on skeletal surveys to exclude smoldering versus active myeloma. Okay, so I think the thought is certainly we've all seen these patients where the light chain values can fluctuate over time, and I would tell you that these were confirmed. We didn't react to the first light chain that was abnormal, but notably the patient also has developed a spike within his urine at this point in time. And just to illustrate the data on why the criteria have been changed, and these studies are albeit somewhat small, but this is the basis for the fact that the criteria have been modified to include free light chain ratios greater than or equal to 100, because in this study here, patients whose light chain ratio was greater than or equal to 100 and had otherwise smoldering criteria had a median time to progression of 15 months versus those who had a ratio that was less than 100 with a median time to progression of 55 months. And on the right-hand side of the slide, you can see the data that added in the higher levels of clonal plasma cells that are present. And so based on the confirmation of this patient's free light chain ratio being greater than 100, he would meet criteria for active myeloma and would generally, the recommendation would be to treat this patient. I did repeat his bone marrow biopsy before this to confirm that there were not new additional genetic changes which might portend a worse prognosis, because we know that these things can evolve over time. It was unchanged. He had an 11-14 translocation, and based on this, the decision was made to start systemic therapy. I would tell you, I think we've all been faced with, when these criteria came out not quite 2 years ago, many patients in our clinics who we followed for a long period of time, whose ratio has been greater than 100 for a long period of time, but now they're faced with a change in their diagnosis based on a change in our criteria. I will tell you what I would do, but I'll ask my panelists first how they manage those situations, not just from themselves, but I would tell you I have a lot of highly educated and motivated patients who come with this information and ask how it impacts them. So both questions.
So I think the importance here is to look at the trend, and there's fluctuation in measuring these values. So just because the threshold came down by revamping the staging system, I wouldn't necessarily jump. But in this case, we went from nothing to very little to something. I would at least repeat it one more time to make sure that that's not a lab fluke. And then I would agree with the recommendation we just came up with. But one has to be careful just because there's a new staging system. We shouldn't be jumping. And later on in my talk about how we evaluate response, it'll be even more confusing when you start looking at what level of detection you're going to be calling a patient who is in complete response, stringent, non-stringent, et cetera. So bottom line is trend and time, I think, would be important, especially since this patient is still asymptomatic. So we have a few more weeks to repeat the test and make sure it's for sure.
I agree with that. I think it's important to remember that these tests are not exact answers. They are not pregnancy tests. It's not pregnant, not pregnant. This is a patient that has had a light chain ratio above the threshold for 10 years. And I think reality will always trump all the models.
Absolutely. So for my patients like that, I will provide reassurance. We continue to follow them expectantly, but not change the approach just based on the change in criteria and the setting of all of that. Thank you very much.
After. Nice.
And I will present the third case. My name is Ola Landgren, and I'm from Memorial Sloan Kettering here in New York. And the case I was given is a case focusing on multiple myeloma with kidney failure. 10 years ago, patients with myeloma with kidney failure had a chance of recovery of about 20%. The 1-year survival was less than 50%, and it was really considered a palliative disease state to have a patient like that. Today, the chance of renal recovery is more than 70%. The 2-year survival is around 70%, and it's no longer a palliative disease state. It's rather a medical emergency. So this is the case I would like to present. It's a 76-year-old female who presents with relapsed light chain myeloma. She was diagnosed 2 years ago with light chain lambda myeloma. She was treated with lenalidomide and dexamethasone and obtained a best response of a VGPR. She now presents with serum free light chain lambda at a concentration of 120 milligrams per deciliter in serum, and the creatinine is 6 milligrams per deciliter. The creatinine clearance is 9.7. She has 4 grams of protein in her urine, and it's 3.4 gram of lambda light chain. The calcium is 10.4, so it's on the upper side, and she's on NSAID use. 2 years ago, at the diagnosis of myeloma, this patient had a creatinine of 1.0. So we're now dealing with this patient, and we ask ourselves, how severe is the acute kidney injury versus is there some underlying chronic kidney injury in this lady? So let's take briefly a look at the literature for kidney failure. So there are 3 definitions for acute kidney injury. This patient would qualify as stage 3 acute kidney injury by all these 3 because the increase is more than 3 times from baseline of her creatinine. She does not have any evidence of chronic kidney disease by definition. She does not leak a lot of protein, and at presentation her GFR was in the normal range. So coming back to the clinical situation, what has caused this patient's acute kidney injury? how are we going to set the right diagnosis? Because we know there are multiple explanations that can underlie this clinical presentation. And what are we going to do about it? So I want to go over briefly differential diagnosis of acute kidney injury in myeloma, the pathological classifications. And as you are well aware, there are two major types, the organized deposits or inclusions on the left, and you have the non-organized deposits or inclusions on the right. The organized deposits or inclusions include crystals, fibrils, and microtubular damage. The crystals have multiple myeloma cast nephropathy as the main category on top. In the fibrils, you have the light chain amyloidosis on top. And in the microtubular, you have the cryoglobulonemic glomerulonephritis, and there are a lot of other glomerulonephritis categories as well. On the non-organized granular, you have the monoclonal immunoglobulin deposit disorders, including both light chains, heavy chains, or combinations. And then there is the other category. There are very many details, and due to the restricted amount of time I have, I will just show you 3 pictures of light chain deposition disease on the right. I will show you a picture of light chain amyloidosis, and then I will show you the myeloma cast nephropathy. They look very different under the microscope. The light chains, as you can see on this slide. And here you have the renal amyloidosis in the red color. And then you have the cast nephropathy with the crystals. This last slide, the cast nephropathy of the myeloma kidney, represents about 80 to 90% of the severe renal failure we see in multiple myeloma. So this is the big one. When the light chains come to the kidney has the capacity to do reuptake of proteins, and this happens in the proximal part of the tubule. When there are too much light chain coming into the kidney, it causes a toxic injury. And when the proteins continue to go down in the loop of Henle, together with the TAM horsefall proteins, they produce crystals that clog the distal part of the loop. And this is what we refer to as a cast injury. If you take pictures of what's going on in the kidney, on the left, this is the at presentation biopsy in a patient like this. And if you don't do anything, or if you don't get it under control, only a few weeks out, you have a lot of scarring in the kidney. And this is irreversible. So it's an emergency situation. You need to do something right away. You don't want to end up on the right. So I'm going to soon ask you if you're going to do a biopsy of this patient. So before I go there, if you do biopsy in people in general to figure out what's going on in their kidney, what's the risk in terms of bleeding? This is a study from the UK, including almost 2,000 patients. Around 150 of them had plasma cell disorders going on. And in this study, there was a 4% risk of bleeding in the general population, and the same was true in the population of patients with plasma cell disorders. Before I ask you the question, I also want to point out that if you look in the urine, for patients who do have kidney failure in this setting, there are 2 major types of signatures that you see for the proteins. On top, you see the selective proteinuria, where you have dominance of light chain. And this is the myeloma cast nephropathy. On the lower part of the slide, you see the non-selective proteinuria, or albumin predominance, which is what you typically would see in AL amyloidosis, the monoclonal IG deposition disorder, or other monoclonal immunoglobulin-related or unrelated conditions. So here is the case, 76-year-old lady diagnosed 2 years ago with light chain lambda myeloma. She was treated with Lan-Dex, obtained a VGPR. She now comes with a serum-free light chain lambda of 120 milligrams per deciliter and creatinine of 6. The clearance is 9.7, 4 grams of protein in the urine, 3.4 gram is lambda light chain, calcium on the upper bound of 10.4, she's on NSAID. This is the only question I'm going to ask you. Would you biopsy this patient? Yes, no, or seek a specialist opinion? I guess ask your friend next door. So most people would biopsy. That's around 50%. And then we have 32 and 19%. So I'm going to ask my colleagues. I do the third here. Ask the colleagues. Ask both colleagues.
So we have the advantage of having seen these presentations before, so we learned. And I hope. So this patient already has an established plasma cell disorder. Therefore, a biopsy, even though it seems to be safe based on the data you just showed, is really not something I would pursue.
So Carol, can you give some more detail? Why would you or why wouldn't you?
So I too would not pursue a biopsy, but I would have not pursued a biopsy even before I saw the case. And that is for a couple of reasons. One is we have an established diagnosis of myeloma. You have a urine that shows predominantly light chains as the part of the proteinuria, putting you more in the myeloma cast category. And it's going to delay what this person needs, which is therapy for their myeloma, because the greatest probability of recovering this patient's kidney function is getting rapid therapy on board. If it is an ATN type process, it's probably an addition, but there's enough light chains in the urine that I don't need any more information.
Thank you. Yeah, my answer would be no biopsy. The patient has either the myeloma kidney with the cast nephropathy, which is the most likely explanation because she had a lambda light chain and the protein, as I indicated, included mostly lambda light chains, and there was no underlying kidney disorder to begin with. Because she was on NSAID and the calcium was on the upper bound, I guess you could also speculate that could be some acute tubular necrosis going on. So things to do here is to treat the hypercalcemia, to give bisphosphonates, high-dose steroid or calcitonin, to stop the toxic impact on the kidney, stop the NSAIDs, and make sure that the patient receives at least 3 liters of fluid per day. There is no support to alkalize the urine in the literature. Looking at the literature in relation to kidney recovery and the impact of free light chains, if you can normalize the free light chains, you're going to improve the patient's outcome. So in the responders that do recover their kidney, most of those patients have a decrease of the free light chains. So how can you correct the light chains? I'm going to turn over to my colleagues here. Would you do any extracorporeal plasma exchange, or would you think of therapy, or both?
So the figure here illustrates that performing a plasma exchange is unlikely to be beneficial. On the other hand, this patient does need treatment, and there's a high likelihood of response, which if done in a timely fashion, truly as an emergency, should reverse in the majority of the cases the kidney function. So in this case, treatment of the disease would be my choice.
Any other opinion?
I think that's what I would do. But I think the other thing, if you just think about what plasma exchange is doing, it's taking things out of the plasma. And our problem isn't that. Our problem is likely myeloma cast nephropathy. And plasma exchange will do nothing for the cast within the kidneys.
I agree with that. This is the largest randomized study looking into the impact of plasma exchange in this setting, and it shows there is no benefit doing that. It will only delay what we need to do, which is on the next slide. It is to start myeloma therapy. That is the right answer. And the International Myeloma Working Group guidelines that were published this year in Journal of Clinical Oncology recommend the use of proteasome inhibition in combination with dexamethasone, and also point out that one can consider adding a third drug. This slide, it's a little check to make sure that you're still awake, because it's better to be low, the orange here on this curve. This represents the proportion of patients that remain on dialysis, so it's better to get off. So therefore, it's opposite to many other Kaplan-Meier curves we look at in hematology oncology meetings. So bortezomib is better than thalidomide here. This is also a slide looking at another proteasome inhibitor, carfilzomib, showing that there is no difference in carfilzomib clearance or exposure among patients with normal renal function compared to patients with renal impairment in different categories. Also, there is no difference in terms of adverse events between these renal groups. There's less information on carfilzomib and much more on bortezomib in these settings. So the clinical message to the treating physician is multiple myeloma and acute kidney injury is a time-critical emergency. Get the diagnosis and start chemo. You don't need a kidney biopsy in the routine care. The bone marrow defines the treatment. Look at the blood tests. In this case, you saw the light chains, and look in the urine, you see the light chains there. You have the diagnosis. Thank you very much for your attention.